Hello and welcome once again to the video series Steer by Dr. Amdekar's team. I'm Dr. Tushar Maniar, pediatrician from Andheri, and I'll be talking on language developmental delay today. As you know, speech is the production of intelligible words, and there are disorders of speech which include articulation, fluency, phonation, hesitancy, etc. But language, on the other hand, is the mental act underneath this whole thing. And that is what we are going to discuss today. Language is made up of verbal communication and non-verbal communication. In non-verbal communication always precedes the verbal communication in development. Also, there is a receptive language and there is an expressive language. What do we understand by that? When something is conveyed without spoken words, it is considered as the receptive language. And when the person is spoken to, then words are being uttered, that is considered as an expressive language. To give you an example, a newborn infant, by the time becomes 4 to 6 weeks, learns to recognize mother's facial features and expressions and becomes quiet when the child sees the mother. This is the non-verbal receptive communication. As the language development improves, the infant is able to respond by smiling back when he or she sees the mother, or if the mother goes away, the child can respond by frowning or by crying. That is the non-verbal expressive communication. As the time passes and the child matures further, by 7 to 8 months, they are able to follow commands without having used the words. That means if you say just wave the hand, they will understand it means bye-bye. And that is the verbal receptive component. Finally, when they are 1 year old, they are able to speak words clearly, and that is the verbal expressive language. This is considered as verbal expressive only when the words are addressed appropriately. And as Dr. Samir Dalwai normally will teach you, that they have to be IMP. That means they have to be interactive, they have to be meaningful, and they have to be purposeful. The interaction further develops by the age of 18 months in the form of pointing. So this is how different types of language development occurs. Now let's look at some of the normal milestones of language. As we discussed, by 6 weeks, the child develops social smile. By 3 months, the child has learned cooing. Around 6 months, there is babbling. Around 9 months, the child is able to understand single commands. By 1 year, child can speak, usually will be able to speak one word or two words. They can respond when called by their name. By 15 months, they are usually speaking three words. By 18 months, they have 10 to 20 word vocabulary. By the time they are 2 years, they are able to form sentences with 2 words. It's important to remember, after 2 years, at 3 years, 4 years, 5 years, they can make sentences of 3 words, 4 words, and 5 words. Also, how clear is the language is also equally important, and so are different communication parameters which go along with language development. We have addressed the normal development. Let's look at some of the red flags and when you would start getting into evaluating the child further. If the child has no social smile by 3 months, if the child is not babbling by 9 months, the child is not responding to his or her own name by 1 year, and the child is not speaking any meaningful word, single meaningful word by 15 months. These are all the red flags. Not pointing or interacting with other children by 18 months is also considered red flag. By 2 years, if they have not speaking language which is clearly understood by the people around them, or by 3 years by anyone, strangers as well as caregivers, then that becomes also an alert sign. Apart from all this, we must remember that any loss of milestone, whether it is language milestone, motor milestones, or any other milestone, is considered a major red flag and has to be evaluated further. Let's look at what are the common causes of developmental delay. The commonest cause of developmental delay one would think about is hearing impairment. And under this umbrella, we will put all the other risk factors which can lead to hearing impairment. Namely, if there is neonatal infection, perinatal encephalopathy, prematurity, small for gestation, intrauterine infection, and so on. We should also consider CNS malformation or neurological diseases under this category of high risk for language developmental delay. Another important cause of delay is lack of stimulation. When there is social neglect or abuse, then there is a very high risk of language developmental delay. But even in an apparently normal family, because of excessive use of screen time and gadget use, there could be lack of stimulation. Let us understand, once we have identified a child having developmental delay, how are we going to approach this patient? So first of all, take a further detailed history of all language developmental delays and make sure that there is delay. Further on, try to classify whether this is only an isolated expressive language delay or whether there is involvement of receptive language as well. Thirdly, look at other milestones. If there are other milestones affected, then you will have to think whether this is an isolated language delay, or if it is language plus communication and social developmental delay, then you will think about autism spectrum disorders. And if there are multiple domains affected, then you will be thinking in terms of global developmental delay. After this, you will have to think about getting a checklist screening done in your clinic. That means you have to go through detailed history and examination of CNS, family history, genetic history, and so on. Or one should do checklist of standard milestone development. Either you can use Denver Developmental Scale or the Indian version of Trivandrum Developmental Scale. For communication and language delay, one should definitely look at MCHET as a screening tool. And we should remember that MCHET screening is advised for every child at 18 months and not just only at high risk or those who have red flags. Here, the results can be as pass, that means we are not concerned about autism spectrum disorder, or as reassess, that means it's a borderline situation and you may want to reassess this patient either with a different scoring parameter or after a few months when further development occurs. And if you get multiple 4 or more abnormal responses on MCHAT, then you would think that you would want to do a formal evaluation. Now, this still does not mean that this child is suffering from autism spectrum, and we are only subjecting them for detailed analysis. After all this, how do you manage a patient who has developmental delay? First and foremost, we must try and prevent this developmental delay, and hence screen time is extremely important to be looked at. All children below 2 years should not be exposed to any screen time. The only exception here is the video calling with their parents, grandparents, or close relatives who are not staying with them. We sometimes overlook the background noise created by the TV which is running in the house, and we think that the child is not looking at it or the child is not paying attention. But remember that background noise is like passive smoking. It interferes with child's ability to understand the conversation that is going on in the room, and that can lead to developmental delay. Repetitive objects and activities should be avoided. It's a great idea to spend more time talking with them and show them books and read them stories. After all this, when you are looking at a child whom you think there is a problem, it's important to refer them early to the specialist. And the recommended specialist here would be a developmental pediatrician rather than sending them isolated to a particular therapist, because the developmental pediatrician will subject this child to formal testing and assess the needs for which therapy is required, how long it is required, etc. And our role doesn't end there. The moment the patient is returned back to you, you should be closely monitoring the response to the therapy, the developmental improvement in the development, as well as the compliance of the patient with the therapy. With this, let me summarize saying that it's very important to document language development regularly in each and every child, especially in detail for children with high risk. Try to perform screening tests in your office and send them early for a timely referral in order to prevent, detect, and manage language developmental delay. Thank you very much.